of the slides I had planned to cover. So I've been asked to give an update on vaccine recommendations from ACIP, and from the title you can see that I'm going to go out on a bit of a limb and make some predictions about things that are not yet decided by ACIP and haven't been reviewed by the AAP, but I'm thinking maybe coming in the next 6 months. Let's see if I can advance my slides. Hopefully you're looking at my disclosure slide. I'll just cut short and say I have no financial disclosures relative to this presentation. These are my objectives for you. I'm going to update you on the LAIV recommendations for 2019 and 20. Describe factors that might be considered going forward in giving Tdap boosters. That's one of the future topics I'm going to predict we'll be dealing with in the next year. Review meningococcal vaccine recommendations because they remain the most confusing of all. And then also talk very briefly about HPV vaccine, and particularly, although it's not a pediatric topic, whether we're going to recommend that vaccine for older adults above age 26. I'll skip the reminder that vaccines are good. I think this audience probably accepts that. Although I will remind you, here's a quote from Tom Frieden, who is the director of the CDC, that vaccines and antibiotics have made infectious diseases a thing of the past. We expect that, but nature is a formidable adversary, and we are experiencing that right now with the measles outbreaks. Here's a headline from New York about excluding unvaccinated children from public places to try to stem the measles outbreak. A second sign on the next slide here from Clark County in Washington, where they're having a measles outbreak, telling unvaccinated children and people to not come into the facility. I updated this slide just a few days ago. It's already out of date. There have now been over 500 measles cases in the United States since January, so the outbreak continues. And there's concern that with the Easter and Passover holidays coming up, people are going to travel, including from some of the places where outbreaks are occurring, and potentially export measles to other places around the United States. So, since we're started late because of the technical difficulties, I've summarized on this slide the main points I'm going to cover. There's a new format to the CDC immunization schedule, which I think makes it much more useful. Live attenuated influenza vaccine is back and being endorsed by both AAP and CDC for the coming influenza season. Tdap vaccine boosters might be recommended for people other than pregnant women in the coming year. One of the two vaccine products has now been licensed by FDA to be used as a booster, so we'll talk about that. In addition, meningococcal B vaccine boosters were just discussed at the ACIP meeting in February for high-risk individuals, so it's possible we'll be giving boosters for Men B also. And then HPV vaccine is licensed now all the way up to age 45, but at the moment there's no recommendation from CDC on how to approach older adults. Here's a picture of the first page of the new schedule. Hopefully you've already seen this. It provides a nice listing of vaccines and the brand names to help keep them all straight. The main part of the table is very similar to what it has been, with color coding to guide you towards vaccines that should be given routinely. That's the yellow color. The green bars indicate time periods where children are behind and need to be caught up on vaccines. The purple colors have special recommendations for certain situations. So for example, if you look at the measles, mumps, and rubella line between 6 months and 12 months, there is a yellow bar, which means if infants in that age group are traveling abroad, they should get the MMR vaccine. So this is really a note to you to check the details to see exactly what indications are in play for those age groups where the purple bars are indicated. And then you can barely see it here, but towards the bottom there's a light blue bar, which is for vaccines that are recommended on a subject to individual clinical decision making. The most common of those is meningococcal B vaccine, which at this point we still don't have a routine recommendation for everybody. We're using individual decision making. The next page, table 2 in the new schedule, is the catch-up schedule, which is where you'll find out how short an interval you can use to catch people up on vaccines. And then table 3 has been in the pediatric schedule for a few years. It's been in the adult schedule much longer. It lists various conditions across the top of the screen for which certain vaccines are either indicated or contraindicated or are used in special circumstances. You can see there's a series of different color coding lines across the bottom that helps you interpret what the colors mean. So for example, pregnancy has red bars for LAIV, MMR, and varicella because those are live virus vaccines and are not recommended during pregnancy. And the other colors I'll let you read for yourself since we're a little short on time. So these are good resources to have available in your clinic so that you can quickly scan them and decide if a patient with a certain risk condition needs any of the vaccines in the schedule. And lastly, there's a notes section, which is where all the details are about spacing and timing of doses and indications. So I encourage you to make sure you have the latest version of the schedule. It is easier to navigate and more complete than we've had in the past. I'm going to now move into the specific vaccine section, talking first about influenza, reminding you that we care about all age groups from unborn babies all the way up to seniors when it comes to influenza as a disease. This is a graph of this year's influenza season. If you have the feeling that influenza has been lingering on for a long time this year, that is correct. You can see how broad this peak of activity is. It's gone over several months. Usually it's a narrower peak than that. And interestingly, this year we started off with a predominantly H1N1 season, but late in the season, H3N2 influenza A viruses have come up. And that's a new pattern that we haven't seen in at least in the last several recent years. We've hardly had any influenza B vaccine this year. And the reason this is particularly important, this rise in H3N2 late in the season, is that sometimes predicts what's going to happen next year, and that may carry over. And that's going to be relevant to our discussion about the LAIV nasal flu vaccine, because that vaccine, although it had a lot of problems with H1N1 strains, was actually quite good for H3N2 strains, and that's among the reasons that the recommendation has been reinstated to use that vaccine in the coming flu season. This just shows underlying risk conditions that lead to hospitalization. My main point is the very bottom line, that unlike adults, children who get hospitalized with influenza 50% of the time have no underlying health condition. So they're perfectly healthy children who end up getting severely ill with influenza and getting hospitalized. So a reminder to parents that immunizing all children is important, not just children who have high-risk medical conditions. This is the effectiveness from last year's vaccine, which unfortunately that's not bad, overall effectiveness of 47%. We would clearly like a vaccine that worked better than that, but on average, that's a pretty good season for influenza vaccine effectiveness. Those effectiveness numbers are only generated from the injectable vaccine because not enough of the live attenuated vaccine was used in the past season to give us data, because AAP was not recommending its use. So it's sort of a catch-22. We wanted to get more data to show that the vaccine worked, but people aren't using the vaccine, so we still don't have adequate data from the United States. Importantly, for next year's influenza vaccine, which hopefully you may have already pre-booked your orders for, there are 2 new strains. Both influenza A strains are new, and one of them was delayed in the selection. The influenza A H3N2 wasn't decided on until mid-March. That's about a month later than usual. And that has to do with the fact that H3N2 viruses around the world are changing relatively quickly right now, and they wanted to get the best choice they could into next year's vaccine. Since the decision was delayed a month, it's possible that the vaccine supply will therefore also be delayed in the fall, because it takes a certain fixed amount of time from the time the strains are selected until the vaccine can be produced. So one thing I'm going to go out on a limb and predict is we may have a little bit delayed vaccine shipment this year because of this delayed selection of the strains and going into the vaccine. This is last year's table of available vaccine products. I just want to make a couple of comments about vaccine products quickly. So I've highlighted in red the two products that are not made in eggs. They are made in cell-free systems. Originally, we thought of those as being useful for people who are egg allergic, but we've actually now learned that all of the vaccines are safe in egg allergic people. But the other thing that's been identified just in the last few years as these vaccines that are not made in eggs seem to work a little bit better and aren't as subject to changes that occur during the manufacturing process. So nothing is changing for this year, but I think going forward in the future, we may start to rely more heavily on these vaccine products that are not made in eggs, not because we're worried about egg allergy, but because they may work better. So stay tuned for that story. And then lastly, I want to emphasize that we now have 4 different products that are licensed down to 6 months of age. The one on the bottom right, it still says 5 years and older because this is last year's table. But Afluria IIV4 is now licensed down to 6 months as well. So we have 4 different products to choose from for our infants. And then, as you all know, for many years, we were using a different dose for children up through 35 months of age, the 0.25 ml dose of the Sanofi product Fluzone. That product is now licensed as a 0.5 ml dose for next year. So that should hopefully cut down on confusion about what the right dose is so for all of the products, the volume is going to be the same dose as it is for older children and adults. Nothing's changed with the 2-dose recommendation. Children under 9 years of age who haven't been previously immunized with at least 2 doses of vaccine need to get 2 doses next year. Otherwise, 1 dose is sufficient. All right, let me quickly get into the story on LAIV, starting off by reminding you that the reason LAIV was not recommended for the last season is that for 3 years in a row, it did not perform very well, and there's the data showing that. Most of the problem was with H1N1 viruses, and of course, we had a predominant H1N1 season this year. So what's new? Why is LAIV back? Well, the AAP reviewed all of the data from the current season in other countries, and LAIV continued to be used in many other countries, and in the UK in particular, they demonstrated very good effectiveness for the new product LAIV that's now being marketed by the company. We also already had, and we may have talked on last year's webinar, about a small amount of nasopharyngeal shedding data that suggested the new formulation was working better. Historically, the live attenuated vaccine has been better for H3N2 and for influenza B, and in many cases better than the injectable. So part of this reinstatement of the recommendation is a prediction that we may have more H3N2 disease next year because of these evolving strains that I talked about before. We all know that young children prefer the live attenuated vaccine in many cases. It also is easier to give in non-medical mass vaccination settings like schools. So for all of these reasons, the AAP has decided to endorse LAIV for the coming season as an equivalent choice. In other words, you can use either the injectable vaccine or the nasal vaccine. I will point out that we're still missing true effectiveness data for the new formulation from the United States. We're relying on data from other countries who may or may not be exactly the same as us in terms of background rates of immunity. And so we're going to have to stay tuned in the coming season as we get more data on use of LAIV and keep tracking whether its effectiveness has been restored. Bottom line is you can use either LAIV or injectable vaccine for next year's season. And here's the actual recommendation. I won't take the time to go through the details, except to remind everybody that we need to keep working on getting pregnant women immunized because, number one, they themselves are at increased risk when they're pregnant from influenza, and number two, it prevents influenza in the infant after they're born. So stay tuned on the LAIV story as new data comes forward next year. Let me shift gears and talk a little bit about pertussis. We've spent a lot of time worrying about pertussis in the last few years due to a series of outbreaks. Here's data from California. Our last outbreak, you can see on the left-hand side of this graph, is from 2014. Typically, pertussis peaks in 3 to 5 year intervals, so we are due or maybe even past due for another outbreak. It's possible that we're not going to see that because we have increased our vaccination rates substantially in the last 5 years, particularly for pregnant women, so we're going to see less infant disease than we used to. But, you know, I think it's premature to say that, but it's at least a hopeful sign that so far we have not seen the typical resurgence of pertussis. The epidemiology is, of course, quite variable across the country, and I didn't look up what the story is in Illinois. So if during the question and comment period anyone has that information, it would be great to share it. Another reminder about the challenge we have with preventing pertussis. Although we are routinely immunizing adolescents at age 11, that vaccine effectiveness wears off quite quickly. This is a study from Northern California Kaiser that shows just 4 years after vaccination, the effectiveness is way down at 10%. There are other studies that show similar findings, which is why up until now, we have not been boosting everybody routinely with Tdaps because we would have to boost every 3 or 4 years, and that's basically not cost effective from a public health point of view. But booster doses do work, and as I said earlier, the Adacel product of Tdap has been licensed now by FDA to use as a second dose with an interval of 8 years, which I assume was the case simply because that was the interval they studied in the clinical trial. Currently, we are boosting pregnant women with every pregnancy. That is by far our best strategy to prevent infant disease and mortality from pertussis. Those booster doses have been shown to be safe and effective, so we now have ample safety data that pregnant women do just fine getting their Tdap. Otherwise, under the current recommendations, everyone else just gets a single Tdap at one point in their life. But now that this new the vaccine has a new license indication for boosters, we should step back and take some time to decide who we would give it to. And these are some of the considerations. I want to emphasize these are my personal considerations. These are not necessarily what ACIP or AAP as an organization are going to endorse. But I mentioned that I got myself a repeat Tdap once I learned about waning immunity, since I'm a healthcare provider who spends a lot of time around young infants who may have pertussis and I don't want to spread it to other infants. The cocooning strategy that we used for a while to get family members around in a household when a new baby comes home is one consideration for boosters, but I'm not sure if ACIP is going to recommend that. During outbreaks, it would be reasonable to consider boosting subsets of the population who are in a focused area with an outbreak. And then lastly, I think the real reason this is being considered by ACIP is that many providers are not even stocking old TD anymore. They're only keeping Tdap. And so to give the every 10-year tetanus and diphtheria booster that is recommended, we may be able to substitute Tdap as a vaccine product to use. So again, this is all future consideration. It was discussed at the February ACIP meeting. It may come up for a formal recommendation at the June meeting. So just be prepared for some information about using Tdap boosters. Now I'm going to shift and talk about meningococcal vaccines, which are by far the most challenging. The recommendations are confusing. I may have even shown this slide last year because they continue to be confusing. So just a quick overview, we have two very different vaccine types, the ACWY conjugate vaccine and MenB vaccine. Both of those vaccines have two different products. Their brand names are listed there. We have two very different recommendations for the two types of vaccination. The ACWY vaccine is given routinely to all adolescents starting at age 11. It's also given to high-risk individuals all the way down to infancy. And a booster dose is recommended at 16 years of age. The MenB vaccine, we have a routine recommendation only for the small subset of people who are at high risk, and these are primarily people with immunodeficiency, complement deficiency, for example. But the one segment of the population that you all are going to come across occasionally are people living in settings where there's an outbreak of meninge-B. So most typically that occurs on college campuses. And when that happens, the public health authority may recommend MenB dose immunization for the college population to try to prevent an outbreak from spreading. And then I do want to recommend my last bullet here that the MenB vaccines, the two products that we have, are very different from each other. So you can't even mix and match those with assurance that they will work. So it's important that you use the same product that for the first dose that you give for the second and third doses in the subset of people that you're immunizing with meninge-B. There are still a number of issues with meninge-B that are not resolved. First of all, the vaccine doesn't cover all the circulating strains. That's different for the ACWY. That does seem to cover all the strains well. For both vaccines, the immunity wanes over just a few years, so that's an issue, and that is the reason that boosters of MenB are now being discussed. Unfortunately, the MenB vaccines don't seem to reduce carriage in the nasopharynx, which is one of the reasons that outbreaks are quickly aborted with the ACWY vaccine, is that you not only protect those who are immunized, but by decreasing carriage, you even protect those who aren't immunized because the organism is not circulating in the population. We are still waiting for long-term safety data on MenB vaccine, but so far the signs are encouraging. There have been no significant safety issues related to MenB vaccines. So here are the new developments. The ACIP had a fairly lengthy discussion at their February meeting about giving booster doses to people in those high-risk conditions. So this is not for the general population, people with complement deficiency. There is a monoclonal antibody that attacks complement, and people receiving that, which is used for rheumatologic disease. People receiving that are at increased risk of meningococcal disease. If you don't have a spleen, you're at increased risk. Microbiologists, which isn't relevant to an AAP audience. And then the last one is the one you're going to face periodically, and that is during outbreaks. So because of rapidly waning immunity, the booster may be recommended as early as 1 year after the primary season. So that means if you have a patient in your practice that you gave MenB to when they were going off to college, and 1 or 2 or 3 years later that college has an outbreak, there may be a recommendation to boost with an additional dose of vaccine. So again, this is not yet officially been recommended. It's being discussed at ACIP. It hasn't yet been reviewed by AAP, but I wanted you to be aware that this is something that may be coming in the next year. I wanted to remind you that we do now know that college students are at increased risk for meninge-B disease generally. These graphs show the rates of incidence of meningococcal disease in young adults, comparing serogroup B on the left with CWNY on the right. You can see that the CWY rates are now flat between young adults in college versus those who are not. But for MenB, the rates are higher in college attendees than similar age group peers who are not attending college. And this just reflects what we know already about the college environment, that it is a setting where students engage in activities that promote the transmission of these bacteria, and that's why we see outbreaks of disease on college campuses. So let me just remind you of the meninge B recommendations. So for high-risk people, this small subset that you may or may not have any in your practice, we're starting immunization at age 10. For normal risk, that is your average healthy population, you have a permissive recommendation, which means it's okay for you to give men B vaccine, but you don't need to feel compelled to. And the language specifically says that you may be, and the vaccine may be administered to adolescents between 16 and 23 years of age. And the recommendation even includes the reminder that that's going to give you short-term protection and against most, but not all strains of the vaccine, of the organism. So this is my list of people who would be reasonable to vaccinate. Again, kids going off to college because of their known increased risk. Others living in similar crowded conditions in other settings might be something to consider. We know smoking and drinking are independent risk factors for meningococcal disease, so people involved in those activities. There are some pediatricians who give these vaccines to everybody. There are also pediatricians who give them to nobody, and that's the way the recommendation is written. And at this point, I don't see that changing in the foreseeable future. And I think we're sort of stuck with that somewhat challenging set of recommendations. Okay, I'm going to finish up by talking about HPV vaccine. It seems like we talk about HPV all the time, but the reason is that we still aren't getting there with regard to prevention. So instead of boring you with the typical coverage rate data, I thought I would show you this figure, which is number of cancers caused by HPV and the numbers of cases in the United States. And it's sort of crazy to me if you look at those numbers compared to the number of cases of meningococcus that we see, which are in the single digits in most situations, that we are ignoring about half of these cases of cancer, which could be prevented if we only had better coverage rates for HPV vaccination. So somehow we need to keep trying to shift the dialogue. Here's coverage rates across the country. I'm happy to see that Illinois is in the 50 to 59% range, as in California. A few states in the upper Northeast, as you can see, have broken the barrier of 60%. But we have a long way to go with HPV vaccination, and there's a whole host of reasons. Families are hesitant, some doctors are hesitant, but we really do need to get these coverage rates up so that we're preventing cancer. I want to remind you, and one of the challenges for pediatricians in dealing with HPV vaccine is we never see the outcome of the infection. In fact, most people who are infected with HPV have no symptoms and their body's immune system clears the infection, over 90% of the time in the case of cervical HPV. It's a small minority who develop persistent infection with the high-risk HPV serotypes, and they're the ones who go on to get at first abnormal pap smears and eventually cervical cancer or any of the other cancers caused by HPV. So this graph from CDC shows the age at which people acquire HPV-associated cancers. And although cervical cancer does start to go up in the 20s and certainly in the 30s, most of these cancers don't occur till older age group. And the numbers in the circles are the median age for each of those cancers presenting. So it's middle adults to even older adults when we see the consequence of the HPV infection that may have happened in the teenage years. So pediatricians are removed from the disease and therefore don't have quite the same passion for preventing this disease as they do for things that they have personal experience taking care of patients with. This is not new information. The 2-dose vaccine has now been around for a while. I thought I would just remind you of the age cutoff. If the first dose of HPV is given at age 14 or younger, then you only need 2 doses. It doesn't matter how long ago that first dose was. So in other words, if a 14-year-old was immunized 4 years ago and is now 18 and showing up in your office, you just need to give a second dose and you're done with the series. Once you hit 15, then you need 3 doses no matter what. So if your first dose is at 15 years of age or older, you then fall into the 3-dose recommendation. There's some bright news about HPV. We clearly know that it works. This is some data from Cincinnati looking over 4 different time periods. That's the study waves across the bottom of the graph, starting from the very beginning of HPV vaccination in 2006 to up until 2016. And then it maps the rates of disease in the top line caused by all 9 serotypes that are in the vaccine. And the bottom line is actually the 4 serotypes that we started with in the original vaccine, which has been used for a longer period of time. And you can clearly see a measurable decrease in the rates of HPV infection in the population. So the vaccine is working, even though we're only getting it into 50% of people. And then even more exciting than that is this data, which is a little subtle and hard to see, but if you look at the middle line that starts at 32.4 on the left for the 4 serotypes that were in the original vaccine, we are seeing decreases in infection even in people who are not vaccinated. In other words, we are seeing herd effects or protection of the general population by decreasing the circulation of HPV in the community. So if we could get our vaccine rates up to 90%, then we would certainly be seeing impressive herd immunity as well as individual protection. So we have our work cut out for us. A reminder about the recommendations, and this is one more thing that's likely to change in the coming year. We currently have a different age cutoff for females and males. In the young adult year, female routinely immunized up to age 26. Males up to age 21. The CDC is talking about harmonizing that and making it just 26 across the board. A reminder, there's no recommendation at this point to revaccinate people who completed the original series with the older vaccines. So that is still not recommended. And we're all staying tuned for new recommendations for adults 27 through 45. So if you missed the news, in October of 2018, the FDA approved the HPV-9 vaccine for adults all the way up to age 45. And we're waiting for CDC to give recommendations on who should benefit from that. So potential future HPV immunization recommendations, we continue to emphasize that 11-year-olds be immunized, although I will say there's been some discussion at the Committee on Infectious Disease for maybe dropping that age even a little bit younger. We know that younger adolescents respond better to the vaccine, and one line of thinking is that if we drop it to age 9, parents won't be so concerned that the sexual transmission nature of HPV needs to be discussed in the same context as recommending the vaccine. And I'm going to finish with this slide talking about some future vaccines. You may have heard that there is a hexavalent vaccine that's now been licensed by FDA a few months ago. It covers DTaP, IPV, Hep B, and Haemophilus. That vaccine is not going to be available on the market till at least the second half of 2020, so stay tuned, but it is a new combination vaccine which you might want to consider incorporating into your practice. We're all hopeful that there's been quite a bit of research on universal influenza vaccines, which might get us out of this yearly challenge of trying to round up everybody and immunize them all at once every year. There's some exciting research on needle-free delivery. These are patches that you just put on the skin, like a nicotine patch, and you leave it on for a little while, and the vaccine ingredients get delivered that way. I'm sure young children would find that preferable to the current way we give most vaccines. We clearly need a better pertussis vaccine. Lots of work is going on. I heard recently that one of the companies is working on combining all the meningococcal vaccines together so that we would have an A, C, W, Y, and B. And that might get us out of these confusing set of recommendations, because you would just give that and it would cover all the bases. There are expanded PCV vaccines coming, both a 15-valent and a 20-valent. And so that'll be exciting to further decrease rates of pneumococcal disease. RSV vaccines, both in the elderly and in pregnancy, are in phase 3 trials right now. So hopefully soon we'll have an RSV vaccine at least to give pregnant women and provide protection for infants as a carryover, and then eventually vaccine for delivery in young children. So I apologize if I had to rush a little to catch us up on time, but just in summary, the LAIV nasal vaccine is an option for you in the coming season. Pertussis is still with us, and there may be recommendations coming in the next year for Tdap boosters for some individuals. Meningococcal recommendations remain challenging, especially for meninge B, but there may be booster doses recommended for Men B. We all need to work harder on HPV immunization and getting everybody started at least by age 11. And I think the future is exciting for future vaccines to improve our ability to prevent additional infections. So I'm going to stop there, Anne, and see if we have had any questions that have been sent in to you, or if we can take questions for the last few minutes.
Yeah, thank you, Dr. Sawyer, and to everybody else. Just wanted to apologize for that hiccup that we had with the audio. So it looks like, we do have a couple questions right now. The first one, and just to remind everyone else also that you can enter in questions on the right-hand side of your control panel. Just go ahead, type in the question, and then I'll read them out. So one of the questions is, for patients who need boosters, are we now saying that we give them every 8 years and not for 10 years?
No, I didn't want that. So first of all, there is no booster recommendation yet. So stay tuned for what comes out of ACIP this summer. The vaccine just was licensed at 8 years, and I actually don't really know why that is. But I think if in the setting where we're talking about replacing the TD booster and using Tdap instead, that recommendation will probably still be every 10 years. It's simply to switch out the product. So don't get confused by the 8-year interval that the vaccine was licensed for.
Okay, and then what do we do about kids who had Tdap last year when they were 10 years old?
Yeah, this is something I'm struggling with right now. So, the person asking that question is referring to the subtle change in the language in the ACIP recommendations, which say if you got a Tdap before age 11 as a catch-up, you would get an additional dose of Tdap when you turn 11. So that is the current recommendation, to give a second Tdap once somebody turns 11 if for some reason they got it earlier than that as part of catch-up. The challenge is, in California anyway, we've been more liberal at starting the vaccine series at age 10, back from the time when we had our large outbreak, and some providers have never changed that. And so this is sort of catching them a little off guard. And the intent wasn't to give them 2 doses a year apart. So we may have to change that practice in the light of this new recommendation from CDC and wait until they're 11 before we give them the first and only dose of Tdap.
Okay, and then I think someone has a question about, can you clarify what you meant by the egg-free vaccines being more effective?
So sure, it's a great question, and I don't understand the science of it in any detail, but as you grow the vaccine in eggs, the antigenic characteristics change. So from the time you pick a strain to go into the vaccine and the time that a vaccine comes out of production, it's not the same. And generally, it's less effective than the strain you started with. And that phenomenon doesn't seem to occur in the vaccines that are produced in cells. So you can see a clear difference in the effectiveness of the vaccines in small studies. So I want to make sure that people don't take this too far. At this point, there's no recommendation to prefer one product over another. But this is just an interesting observation in the influenza research laboratory community, that the vaccine changes for the worse as it goes through eggs. And so I'm just predicting for you that if that holds up to further study, we may have a strong reason to think harder about using the cell-based vaccine.
Okay, and then do you know who the manufacturer of the hexavalent vaccine is?
It's actually a combination of companies. I believe it's Sanofi and Merck combined their products together. So I'm not sure who's going to be marketing it or who you order it from. And again, it's not anticipated to be on the market until about a year from now or even longer. So stay tuned.
Okay, and then not sure if you would know the answer to this question, but in terms of the HPV vaccine getting approved for 27 to 45-year-olds, what would the recommended vaccine schedule be for that group?
I'm pretty sure the vaccine schedule is exactly the same as for older adolescents. In other words, 3 doses spaced apart, 0, 1, and 6 months of age. But I want people to be aware that the FDA licenses the vaccine and gives approval for it to be used on the schedule that was studied in clinical trials. The CDC may change that. They may change the interval and occasionally even the number of doses. So until we get a recommendation from CDC, we're not going to know exactly how to use this vaccine in older adults.
Okay, so that looks to be all of the questions for right now. I'm going to leave the question box open, but I'm going to quickly go ahead and show everybody what your next steps are going to be to conclude the webinar. Just to let everybody know, we do have another webinar coming up next Thursday, and that one would be about the measles updates and all the outbreaks that are going on right now. So you can go to that link below to register for it. And then, so as I mentioned at the beginning of the webinar, everyone will receive a copy of the PowerPoint slide, a link to complete the evaluation, and a link to the recording of the webinar by end of business day tomorrow. And then everyone has to complete that evaluation by April 30th, 2019. After that date, the evaluation will be closed and nobody will be allowed to fill it out or receive a certificate of attendance and or continuing education credit for this webinar. And then everyone should be receiving their certificate by May 7th of 2019. So I wanted to thank everybody again so much for joining us on this webinar and for, powering through with us when we had a little bit of difficulty earlier on in that. And thank you, Dr. Sawyer. We always really appreciate your webinars each year and just hearing new insights that are coming for the future of vaccines. Okay, I hope everybody has a good afternoon. Thank you.
Thanks, Ann.
Thank you.
Yay!